Let us now begin. So, for this panel discussion on the topic of deliberating the future of diagnostics, what's next, we have some very eminent dignitaries present with us, both virtually and physically. For virtually, I invite Mr. Adam Yen, who is the Vice President of Business Development of aetherAI Co. Limited from Taiwan. Welcome. To join us physically on stage, I invite Dr. Nilesh Shah, who is the President and Chief of Science and Innovation of Metropolis Healthcare Limited. Welcome, sir. Next, I invite Dr. Avi Nahar, who is the Director of Sales at MEDGENOME Labs Limited. Welcome. I also invite Dr. Deepak Sanghavi, who is the Associate Director and Chief of Laboratory at SRL Diagnostics. Welcome. Next, to join us physically on stage, I invite Mr. Hasmukh Rawal, who is the Managing Director and co-founder of Mylab Discovery Solutions. Welcome. I also invite Mr. Niraj Desai, who is the business head at CrelioHealth. Welcome. And last but not the least, I invite Dr. Anirvan Chatterjee, who is the co-founder and CEO of Haystack Analytics. Welcome. Dr. Anirvan Chatterjee would also be leading this session. So over to you, sir.
Sorry to pull you back from lunch, and no, but I think we have some amazing panelists here, and it's my honor and pleasure to share the stage with such eminent industry leaders, and dare I say disruptors, and the designers of the future of Indian diagnostics and healthcare. Many, if not each one of you, our panelists, rose to the occasion as India faced the COVID challenge and provided unwavering support and services to help our country stand tall as the rest of the world were trying to find their feet. So I take this opportunity to thank each one of you for your unwavering commitment to bringing healthcare closer to us. We all recognize that advancements we have made in response to COVID are here to stay. More importantly, we are riding this wave of new age diagnostics where technology is going to bring unprecedented scale of diagnostics delivery. Very broadly, there are two major shifts underway. One is point of care testing, and the other is AI and big data led pathology and radiology. These are some of the things that I want to deliberate today with you. The accelerated validations of biomarkers means that there are several conditions for which tests which are done today in labs are coming closer to the point of care and possibly also coming to wearables. And on the other side, with newer diagnostic tools such as genomics and AI-based inferencing, the labs of today are probably going to become highly sophisticated deliverers of new technology. Concurrently, as we are actually moving into a space where the data from diagnostics is coming from point of care and deeper data is coming from the laboratories, maintenance of medical records and health records becomes very complicated. And also, we should not be losing out on the opportunity of deriving value from those tests as well. So with the panel that we have today, we would like to talk about some of these issues. And the questions that I have with me today, hopefully, will give us some direction in how you are thinking these will move. If I have your permission, I will start with that then. Sure. So now starting straight up, the first one to Hasmukh, I think, has the pandemic highlighted the need for development of self-test kit, and with the new variants further accelerate such testing?
Thank you, Niraj. Definitely, the pandemic has highlighted and shown the new era of diagnostic testing, and home use testing was one of the new initiative where most of, not only India, but most of the parts of the world have accepted. In fact, it has happened for the first time where infectious disease testing was allowed to be done at home, and infectious as severe as COVID, which was highly pandemic. It shows the value and importance of testing, provided it is done at a convenience and at a simplicity. If we all remember times of second wave, where home use testing was not yet there, we could see the pressure it has built on a healthcare ecosystem of India, where most of the people were lying and waiting for 2 or 3 or 4 days for their reports to come. Most of the times, the samples were even not getting collected. There were not enough phlebotomists to do it. And it's not a problem of our healthcare ecosystem. No matter whether it is India or any country outside, it is very impossible to build the healthcare infrastructure overnight to address such pandemic. But what self-testing did in wave 3 maybe, there was not much pressure on the on the healthcare infrastructure. The power of testing went to the people, and most of them could do it, provided it was very easy to do it and very easy to report it. Uh, Also, government supported to accept those reports as a confirmatory and allow the further treatment on those, on the basis of those, number one. And number two, they also allowed insurance and all other further claims, like most of the schemes of government of India, to be allowed on such tests. So I think home testing is something where most of the industry would move over a period, but also it requires a lot of improvement. As the new variant will emerge, if the power of testing can be given to the people, and also the test can do it as accurately or as close as a point of care test, not if it has a lab, full grown lab test, I think that would be the future where most of the governments, regulators, and healthcare officials would like to give the emphasis on in the near future. That's what I believe.
Thank you, Hasmukh, for that amazing insight. And I think a couple of things on the support from government and the focus on infectious is key for this change to be taken forward. Dr. Nilesh, what do you think with the current price disruptions, the impact of the current price disruptions happening in the diagnostic field, will the franchise model and network creation get negatively affected?
So I think price disruption is lots talk about these days. But I must tell you that whatever I tell you, it will be all guesswork, because every person reacts to it very differently. Somebody will take it to heart and make all changes. Somebody may say nothing will happen. It had happened in the past and it will keep happening. I will stay what I am doing good, and that may continue. And I may tell you that none of them could be wrong. The reactions will be seen, but it will be very different reaction from an entity to entity. So let's divide into two sides. A conservative approach, or you can say liberal approach, where we say nothing is going to happen, or an approach where this disruption may affect the industry and things may change. Now, if I have to talk, wear a hat of conservative approach. Apologizing for my voice today is not good, so I hope you can manage that. So there have been price disruption in the past, recent past, and also going to be in future. So far, whatever price disruption occurred, they were more in B2B space, where channel margins and all got impacted. The net realization for person who is doing the test kept on going down. These have been in history, and whenever this happened by one or two organizations, and then later on multiple organizations, ultimately market grew. The still premium players remained premium, and economy player remained economy player. That continued. It's like when Tata Nano came, other car companies did not shut down. More expensive models of cars still kept on coming, and they are also selling. None of them got shut down. So the approach of price play, if I wear my conservative hat or a liberal hat, not reacting also is not a bad thing. I want to also tell you that this price change, the price reduction or low pricing has not been uncommon for ages. Every location, there are labs which are charitable labs. They are very low price. But still premium players have their own say and people go to that premium player as well. So this is my one side of thought. Second side, when we think about an approach where a group of people, group of labs or a diagnostic center feel, I think we should react to it. The reaction will be all also two side. There will be class of people who would say all these reactions are occurring only in wellness space, not in illness space. In wellness space, yes, people are very conservative about the cost. They are worried about not spending too much and so on. And that is a market which is getting attracted. There will be another class of people who would say, no, I think it is going to touch illness also. So there will be again two classes. I'm just opening your mind. I'm not giving any view to it, but this is how things are reacting right now. Illness patient who is connected to a doctor requires much beyond just the result. They require a lot of technical support. At times they want to talk to the doctor and so on, which usually with a mass scaling to the level which right now many of the aggregators are engaged into, it will be not feasible. Also, many a times turnaround time becomes a problem. See, there are three factors patient is looking at. It's price, turnaround time, and good service. Doing all three simultaneously is not possible. So that factor also is in mind. So let's talk about in case there is a disruption, price disruption, which lasts longer time. I don't think it will be indefinite, but it lasts a little longer. How it will impact various aspects. So let's take network and franchisee aspect first. I feel all the channel margins and all may get hampered and network expansion may have to change in different way. It may not happen that your associate, a franchisee, he will be able to cater to all group of tests for you. Entry level routine test, probably he may have to compromise on margin. But then semi-special and special test, the room opens. So network expansion may happen, but it will get some variation like that. Coming to quality and service, what will be the impact? On quality side, again, there are two approaches. There are people who will take shortcuts, and I do want to discuss that more in detail to cut the cost. But I must tell you, cutting cost beyond a limit is just not possible. When you have decentralized operations, it's not possible. You may have to do a lot of centralization to cut the cost. So by and large, I think cutting cost just by compromising quality may not be a good idea. And I think good players, good labs will not do. And the labs who cannot sustain this, they may close down. In India, I'm not seeing future where small labs will close down. I frankly feel that in India, the trend, the mindset is that doctor wants, along with the report, a lot of support, which local labs provide very, very well. And I think that replacement is not possible, even if you scale down to all the location and start giving low price and all that, that cannot be changed. So my personal feeling is that probably the small lab are there to stay, grow and sustain this price pressure also. So this is what I want to say on quality service and network, how price disruption. So I can't give you one line answer. This is what going to happen because view will change and it's too recent and everybody may take different approach.
Thank you, Dr. Shah. So I think clearly we're kind of gravitating towards a point is one is the new age of testing that we are seeing from point of care. And here is the big divide between decentralized and centralized. Now, if the costs have to be met, making them more centralized to assure quality. And well, some of this conversation is also happening on Twitter for the past 10 days on these options. One thing which we are still missing out in this country right now is a lot of talk around the next generation of diagnostics which are coming up, and genomics is one of them. We have with us Avi, Dr. Avi, who is going to talk about this. So from probably one of the earliest movers in this country, MEDGENOME, has a lot of experience in how genomics has panned out in India. And how do you think this is going to pan out as a very new specialized test instead of a super specialized test? And can it be ever affordable, genomics?
Very good afternoon to one and all. And first of all, I am honored and humbled sharing the dais with all the stalwarts of the industry. So thank you for this opportunity as I represent MedGenome Labs Limited. So as you rightly said, Anirban, that we started in 2013. We are almost coming to a decade experience. Having sequenced more than quarter genome samples, we are still evolving and learning. There are so many nuances which we get to know every day. And so to my opinion, a very straight answer to your question that are we discussing something which is in future, I would say future is already here. We are living it day in, day out. But if you say, will it become specialized from super specialized? I would say there's a long way to go there. The sole reason is that the complex science behind genomics, it's not very, very straightforward. Machine, although plays a part in sequencing, but there's so much more pre-sequencing and post-sequencing where lots and lots of manual intervention is still required. So although we talk about artificial intelligence, machine learning tools, they are still evolving. And so much so that not only from the laboratory perspective, from the indications perspective, from the doctors who are prescribing, they are also getting to know very, new areas of or arenas of, clinical indications which they want to focus. And so to say, earlier our go-to target audience were always super specialist doctors, whereas that also is changing now. We are going to more and more obs-gynes. We are going to more and more maybe family physicians who are understanding that there is something called genomics and there is a test in genomics. But again, what are the indications? Which test will fit which condition more appropriately? Like we were discussing just before coming here, whether microarray will be an answer or an whole exome sequencing will be an answer. So to my opinion, it will not become specialized in coming few years at least. It is still evolving. And coming to affordability. So what I would again say is, we have already come a long way. There were times 5 years back when one whole exome sequencing used to cost almost ₹1,00,000. And the report would come, say, somewhere between 75 to 90 days. Now today, as we speak, it has become as low as $250 per sample, which is approximately what, 15, 16,000 we are talking about per sample. So huge reduction in the cost. And this is all because many partners came together, industry players came together, collaborated, made a huge impact on awareness, made it a volume game. Samples started increasing. Turnaround times are now so critical. Now, the exome report, if someone wants, focuses, there is a possibility that you can churn out a report within 14 to 15 working days. Imagine coming down from 90 to 14 days. So that also brings more and more accessibility to this test. And with more accessibility comes more affordability. Government also has realized, just day before yesterday, the rare disease cell of the Ministry of Health and Family Welfare, they released a note saying that the financial support limit from 20 lakhs has been increased to 50 lakhs for any treatment of a rare disease. So that shows that the focus is there. That shows that government is also making attempts to bring the cost down. And another example which I would give is like maternal screen markers, which was so much commonly prescribed by all the obs-gynae. Now, we have seen a tremendous jump in sequencing of, maternal blood by non-invasive paternal screening. Now you see, it is almost replacing maternal markers. What does it mean? That at the same cost or maybe just about that cost, in a year or two, we will be doing sequencing tests for the patient. So that's where the affordability is actually being achieved. So rightly put, it is going to be more and more affordable. And even though if it is not, if it adds value to the clinical management, I think there will be solutions. There are many NGOs coming forward. There's many, with again, to take Nilesh sir's thought that price disruption. So this is also part of that price disruption with more and more players coming in. And this all disruption It might be good, bad for the industry, I don't know as of yet, but it is certainly going to be a boon for the population at large. And for the social cause, it is going to be a game changer for sure.
Couldn't agree more. I think non-invasive prenatal testing itself is probably going to stand out in the years to come, which brought genomics closer to the medical fraternity. I mean, with several players now coming in, and that's the time it kind of takes for people to get comfortable with a new technology, right? I mean, same with AI and ML, right? If we look at 7 years back, AI running an MRI and giving a report, uh, and then now it's almost here. I mean, well, not Mumbai, but I mean, pretty much here in the world. And I think that's the change that we are seeing. And I'm just now realizing that while when I was looking at the panel and looking at the my questions, I did not realize how diverse it is going to be. And I'm kind of trying to figure out how will I put it back together. Because we've gone from COVID testing at home and touched upon the government. Fantastic point there. And then, Dr. Nilesh, I think you've put in the sense of quality and turnaround time fair and square in this discussion. Turnaround time, we have come from 90 days from 14 days to from 90 days to 14 days in genomics. But then the question that you raised is interpretation. And thing about diagnostics is one is what you read from the sample and the other is what you read from patient history. And at the end of the day, whether it's where a doctor still asks many times the patient either about the patient's lineage, did somebody, it's an NCD, your parents or grandparents, somebody in your family, and things like that. So context becomes very, very important in clinical practice. And I think all of you here, one thing that you have done very well is taken every technology to the clinician, understand what the clinician needs. When it comes to data, and this is where I'll probably take the question to Adam, if you can hear me, Adam. When it comes to data and with diagnostic players utilizing vast amount of data in terms of clinical parameters and demographics, how do you think AI and ML is going to pan out? And again, some timelines about it, because AI and ML is very interesting when we say pan out and can be a 2-hour long discussion. But what do you think about it hitting the ground and making a difference to the diagnostic players and to the clinicians?
Yes, to solve the clinical problem with AI and machine learning technology, you have to go back to the basic idea of this technology. So this deep learning-based method is a technology that uses computing power and algorithm to digest massive data. So do everything before training an AI model, you have to establish a daily data collection workflow that you can attach an AI on top of the workflow. So the structured data is easier to fulfill this requirement, but when it's come to the like the non-structured data, it is hard to build up an explainable AI for non-structured data like radiology image or digital pathology images that we are working on. So we are trying to push the AI from the end-to-end black box approach to the parameter generating approach. So instead of answering the diagnostic directly, AI can be a new parameter generator with clinical impact. For example, the whole slide image that's generated from the scanners sent into a daily workflow with the digital pathology system. This system can distribute the different kind of whole slide image into different AI model. Each AI model could be generated different kind of parameters with clinical impacts. So at the end of the day, AI will eliminate the boundary between structured and non-structured data by designing a new algorithm. So AI can generate meaningful parameters or indicators that point to the predicting prognosis, treatment response, or patient outcome. For one example that we made an AI for hematopathologist. So the AI model is helping pathologists to generate each cell's parameters for their subtyping. So at the old generations, they have to use their eyeballing and gut feeling to separate the different subtyping. But at the end of the day, we found out that if you use the AI to generate each cell's parameters, you can find out that the cell cellularity and the NC ratios give the huge impact for this kind of diagnosis. You can put it into a very strong cutoff numbers instead of one pathologist gut feeling. We know that if you count out one pathologist or one people or one person to do this kind of diagnostic, it will generate a huge variety from person to person. But in this new world, we are turning the pathology department into the same idea with different kind of like the laboratory work, because we know that in the laboratory they gave each kind of test a very clear cutoff, but it's pretty hard to do it under the microscope or under specific images. So nowadays we can see that we can foresee the near the future that if you can provide the user or even the pathologist a very strong tool that they can turn the non-structured data into a structured data, they will give the like the pharmaceutical development or the different kind of treatment development. You can give them a very strong tool to put the different patients into different groups and give them a proper diagnostic or even the proper treatment. Thank you.
Thank you, Adam. I think I'm going to pick up on the last bit that you say that it is, of course, as an AI tool, it's learning. It's learning in a diverse environment because you're deploying it across different places, which means it's probably seeing the widest images that you're looking at, or the widest interpretations that one is looking into, and probably can learn a lot. The question is, we have a lot of these tools, and I don't think there's while Dr. Nilesh and others can also take this, but Dr. Deepak, I mean, you're probably closest to the clinician with your not just diagnostic network, but also in hospital presence. Now that we're talking about genomics, AI, ML, and all of these tools, these are all tools. Now, what do you think? How are diagnostic players like yourself thinking about participating in this revolution, taking it up, and what are the timelines you are seeing that you will become an active player with these tools that we are talking about?
Thanks, Anirban, and thanks, 𝐕𝐎𝐇 for inviting me for this panel discussion. 𝐼SRL as a diagnostic player is already at the forefront of using the disruptive technologies. So first I will talk about the genomics part. So in genomics, basically we know, we split the word gene and omics. So omics means basically pool of technologies to detect genes. So if it is genes, genomics. If it is proteins, it is proteomics. If it is metabolites, it is metabolomics. So what happens is, in genomics, there's a human genome project. We have a lot of gene sequencing now. There's a lot of knowledge which has come. So this knowledge is nowadays required by the clinicians for personalized medicine, for targeted therapies. So in cancer, in infertility, in preventive medicine also, like diabetes and cardiovascular disorders, there is a targeted gene that the clinician knows that if you give me positive or a negative, I can give a definitive treatment to the patient. So genomics has become a front runner, and SRL as a lab, we are already having a very extensive menu on genomics. We are having high-end technologies like next-gen sequencing. We are having a good panel of doctors who can now discuss with the clinicians, give suggestion to the doctors. This is kind of a part of genetic counseling. So when you use everything, then the genomics can be given like a proper suggestion to the patient, and more patient care can be happening. So SRL is doing this, and we are using genomics to the full front to help the patients, and clinicians are getting better reports as targeted therapies can be given to the patients. On the second disruptive technology which is talked about is the artificial intelligence. So as SRL, what we have done is we have collaborated with Microsoft. So what we have done, based on a library of 19,000 cases on cervical cancer screening, as well as the breast cancer screening. So when we do that, from a library, we get a lot of data. And this data, with the 94% accuracy that we saw, we are actually reporting cervical cancer on an instrument, which is AI-based reporting. What happens, you remove all the negative cases very easily with this AI reporting, and the pathologist can focus on the specific cases. So consider a workload of LBC or a cervical smear coming 250, 300 cases in a day. How much can a pathologist see? So AI is helping us to remove those negative cases, and all positive cases can be screened very easily by the pathologist and give a better opinion. Similarly, on the AI front, digital histopathology. So what happens, the tissue slides are put on the instrument, you get a lot of images, and you can do remote reporting of those histopath cases. So AI is being used, and it is very useful to the clinicians. Better patient outcome can happen because of AI. And the third topic that I will talk about disruptive technology is the recent use of drones. So if you have heard that now drone companies, even SRL has partnered with one company, the samples can be transported from one location to other without traffic. So drones are helping them. We have also done a successful pilot project where in Gurgaon we transported samples from FMRI hospital to Gurgaon reference lab. So without traffic, the samples can go faster, the samples can be preserved at proper temperature, and this is going to help us in this integrated logistics. So I will talk about this integrated advanced logistics system. Samples transported very fast, and the report can be given very fast to the patients. So we as a lab are using these disruptive technologies to the full strength for better patient care.
That was amazing. I think you traveled a long distance there.
All the three disruptive technologies I wanted to talk about.
And I think it's fantastic because it's good to know what Dr. Avi also said. It's not future, it's right now, right here. If sitting at SRL, this is what you're telling on genomics and AI pathology. It's fantastic to hear that we are all moving towards that. Going to you, Niraj, I think your job is getting more and more challenging with large amount of data coming from different sizes and participants in the healthcare journey of the patient. And I think that's one thing which probably is going to become the biggest predictor of everything that we see from now on, because in data there are two parts. One is the data itself. The second is how you put context around it of the journey of the patient. How do you see this panning out across the quality of care, and how it will improve the quality of care, the reporting with increase in volumes across the tests managed by large and mid-size and independent diagnostics labs? How are they going to manage all of this in one go?
Thank you, Anirban, for the question. So, when we started, we always have been a patient-centric kind of a start that we had, and we believe that data has to be shared among everyone. So, our mission is actually having data access to everyone. So, on that aspect, we work with labs who are doing 10 samples a day to someone who is doing 20,000 samples a day. And overall, we manage around close to 100,000 patients every day on the platform. So overall, I believe that as we move forward, we are seeing that more and more patients are getting educated. They are making the decisions right now. Of course, doctors are helping them, but so having the access to the data is going to be important for the patient right now, as we see more and more patient-centric companies coming in here, like Tata 1mg or Healthians, who are trying to get to the patients directly. So as we grow, we think that we, as a technology provider, what we are trying to do is to make sure that the smaller labs who are not yet seen by everyone, or those who don't have access, we are trying to give them a platform through which they can actually compete with such players and are able to give the patients the data. Finally, the agenda is to make sure that the patient is getting all the data and which can be used then. So one of the things that we have done is we provide mobile apps for the patients and all. So this is 8-9 years back we started with this, when no one was talking about this actually. So we have seen that patients are right now we see around close to 200,000 patients accessing the reports online. more and more, it's like going forward, we believe that with this NDHM being implemented, we believe that this is going to be more important, that all the players can share the data, and also like having a clinical decision support system, as rightly pointed out, is also important, because that will give, because most of the doctors, they might not be knowing few things. So having a support from like established players like SRL, Metropolis, who are actually trying to, like Dr. Shah also pointed out, that they are trying to help the doctors as well. So overall, I think it is like the data becomes the core of all the things that we are doing right now, and like having the interoperability between the players will be the next step. And I think we have already seen that with ICMR implementing the COVID, that the data was shared between like every day, everyone has to get the data uploaded to ICMR, and there was a central repository of all the COVID tests that are happening, like which gives us the next step, that okay, when we go ahead and we implement like across the board, it can be done. So ICMR has given us a direction for that, and I think overall, I believe that that's the future that we are seeing.
Fantastic. Interoperability is a loaded word, and the world has been trying to do it for a while now. I don't know where HL7 stands in India, but I think it in COVID, as we said, we have learned a lot and we have implemented a lot. I believe we have covered most of the things that we wanted to ask. There are a set of questions which I have, which looks like slightly repetitive to me. What I'll do is quickly turn around with each of you to see that we clearly understand that most of the things that we think we want to deliberate about the future of diagnostics is already here. Point of care testing, infectious diseases testing in-house, and reporting it to an ICMR website, whether at least your kids say that we should report it. How many of us we do it, that's a different thing altogether. But the possibility is there. And I think when Dr. Nilesh, as you're saying, price and disruption depends how long, what lasts. But at the end of it, what we all agree is that quality is very important, right? The quality of a point of care testing, the quality of an AI prediction, which changes the life of a patient because a clinician can understand what the patient needs to do, and the quality of information that we get from a large volume of data like genomics. All of this needs to come together for the quality of test that a patient must have and improve. With that in mind, couple of closing lines from each of you. I'll start with you, Adam. Next 5 to 10 years, the top 3 things that you think will move into AI in diagnostics?
Yes, as you can see, and most AI applications are swinging between AI assistance tools and AI diagnostics. So I think everyone treats so-called AR as a unique tool today, but you will not treat like software, web, or mobile as an outstanding technology. But this kind of technology still assimilates into our everyday lives. So in next decade, I think the AI applications will be polarized, as we say. So due to the accessibility of deep learning technology and open source tool, any institutions or individuals could develop essential tools of like the detecting cancers or counting cells. So even the high school students can do this kind of medical AI. But at the other end of the spectrums, the high clinical impact applications will become from the becoming from the pharmaceutical industry or precision medicines. So one of our cutting-edge technologies, as we see, we should have to annotate more than like 1 million bone marrow smear cells to establish just one AI from 3 countries and pass all the kind of different kind of regulations and collect different standing data. That's a huge labor incentive jobs. So it will be 2 different kind of situations. Pretty easy AI, everybody can do this on their own. and the pretty hard AI just coming from the very huge companies or the resource orientated groups. So the development pipeline of the companion diagnostic AI is a resource orientated as we see. So by collecting data from multiple patients, multiple hospitals, and even multiple countries, AI will become the most powerful tool to bring the precision medicine to the next level. Because as we know that the AI, the dilemma of the diagnostic AI, we will see that everybody treat the diagnostic AI as the not the must have, because we know that we ask doctors or physicians or pathologists to give the correct diagnostic as today, even they don't have the AI today. But we know that we could not, maybe our insurance system could not pay more at this moment for a more correct diagnostic. But later on, if the diagnostic connect with a proper treatment, it will become the next level. So we are foresee that the precision medicine is not just precision medicine, not the precision treatment, is the precision diagnostic connect with the proper treatment. So that will become the next level of the AI applications.
Thank you, Adam, for that. Very quickly to you, Dr. Ravi. NIPT, what next in genomics?
So, my opinion, it's just not NIPT. I could foresee that there will be even more disruptive tests coming in, which will give more and more information at an early stage of gestation, so that decision making is quicker, faster, and more mother friendly. So it's just not about NIPT. What I would say is two things. One, the quality of everything we do remains the crux of everything. Commercials are all output of what great efforts everyone inside the lab put on their dry lab or wet lab. So that is going to be the key. The major challenge in any genomics to scale up is, number one, the clinical details, which unfortunately is, taken for granted by many of the prescribers of the test, because there are many reasons for it. There could be evolving manifestation of a child for rare diseases. There could be something else which comes up during the progress of the disease. But at the same time, the clinical and laboratory correlation of a phenotypic genotypic interpretation becomes a major challenge in genomics. Number two is the skilled, competent human resource, which unfortunately is going to be a bottleneck for scaling up. Number three would be end-to-end automation, which still is not possible in genomics. And there are going to be genome analysts doing their job, clinical geneticists writing and interpreting the report. So coming back to what next for NIPT, NIPT is going to be probably a routine test, coming from the super specialized to specialized to routine, certainly. But then we are also foreseeing that something else is coming more. Thank you so much.
Yep. I'm sure that is right on the cards. Hasmukh, you've been listening to all of us, having spoken first. What are the tests that you are putting on our table in the next 5 years, and for tests that we don't have to go to diagnostic labs for?
Thank you, Niraj. So number one, what I believe is point of care testing would be the next thing in diagnostics. What is point of care test? If most of the audience may not have an idea, point of care test is a test where the testing goes more close to the patient, and it is though done by a healthcare professional, but it doesn't require most of the expertise. A normal technician, skilled level person can do it, and it have very minimal step or automation to support and integrate it. Most of the labs today which run, it's mostly hub and spoke model, where they collect everything centrally, run everything centrally, and report it decentrally, which would eventually shift on running decentrally and reporting centrally. So this is where most of the things will happen. If you just want to take an example of COVID, though we had increased the infrastructure of molecular labs to more than 4,000 labs over a period of a short few months, still 5 times more testing happened by a point of care method than a big lab level method. It shows the value and importance of this. And why it becomes very important for country like us is we are a very vast country which has a which has to be reached in depth and breadth of the country, and having a central method of testing would not help. So maybe to add to Dr. Nilesh's point, price is not only the thing. There are so many things which government or a patient would look at when it looks at when they're looking at a test of our healthcare. There is a cost of waiting. There is a cost of not having the right medicine in the time because the test may take 3 or 4 days. There is a cost where you are very concerned for those much period, what will happen next, whether I'm sick or not. So for those kind of things, premium would be paid. And it will be only paid if it is at convenience to the user. So this is where point of care method of analysis would be very important. If you want to ask me what will happen in next 10 years, there has to be improvement where companies like us who are manufacturing solutions has to bring automation, interpretation, AI tools to it to make sure that it is also reported centrally to the lab or the government if needed. If I want to add how the market would move, I think the first interest for the government end would be those of tribal diseases where there are no labs and those people are dying any which ways and nobody is concerned about it. Government would be happy to have a point of care solution. Look at sickle cell anemia. We are world's hub for such disease, thalassemia. And this is where government would address. If I want to see private labs, they would add infectious disease as a first method where the treatment and disease detection has to happen first. Second would be the drug resistance or the therapy lines for those infectious diseases. Third would be the newborn screening. It would reach more to the hospital where the childs are taking birth so that the decision can happen faster. After that, maybe the maternal and child health, maybe after, to make sure that all the pregnant ladies are taken care. And then after that, the disease of chronic or a great threat like cancer. I think this is where the country would move in next 10 years. And I think the diagnostic companies who are manufacturing it, the companies who give these services and the companies which interpret this all have to come together to give a healthy India for the future.
I think that rounds up most of the conversations that we're going to have in the next 5 to 10 years as a diagnostic fraternity. Dr. Deepak, how do you want to relate this to what the government is thinking on Universal Health ID? And your thoughts about is that also going to play up in the opportunities that we're talking about opening up for each of us here in the next few years as far as Universal Health ID is concerned?
On the Universal Health ID, our government of India has done a very good initiative of Ayushman Bharat Digital Mission and Universal Health ID based on National Health Policy. So basically, if we understand what is Universal Health ID, it's a site where the patient gets a unique number. What they do is they put the Aadhaar number, they get an OTP, a unique ID is created. And this patient now can download all the reports which he has done, maybe in a private hospital, maybe in a private lab, maybe in a public hospital, or maybe in a very small lab. All his reports, all laboratories are a very important part of diagnosis. So clinicians wants to know this patient has gone through what all test, maybe because of the chronic condition. So better patient care has to be done. So all these can be stored at one place. So it's a very good initiative and it's slowly picking up. Even in fact, SRL is the first lab which has got integrated with the ABDM, that is the Ayushman Bharat Digital Mission. All the patient results are actually uploaded on the site where the patient can download the reports if they have a unique number and an Aadhaar card with them. So here we are talking about getting patient better care, clinicians knowing what the patient has done from the start till end, maybe 5 years, 10 years, what this chronic condition has led to. So Universal Health ID is a very good initiative and I feel it will open up a lot of opportunities for the private sector as well as public sector because see, public health schemes are going to come from Government of India. Insurance companies want patient data to take out more strategies. All this can come when the data is placed at one place. So a lot of opportunities are going to come for all the sectors because insurance and government and public health awareness schemes, epidemiology will give us a lot of idea. So all this Universal Health ID is going to give. So it's a very good initiative and it's going to be a game changer. And from my side, that is a main point for my side.
Thank you, Dr. Deepak. Dr. Nilesh, as a chief of science and innovation and other things that you do at Metropolis, but as a chief of science and innovation at Metropolis, for entrepreneurs of today, how do you think healthcare has changed for a company which started in early 2000s versus a company that is going to start today?
So if I have to tell you on innovation front, and if I have to take period of say 25 years down the line, I've spent about 36 years in the industry, and what journey I see that 25 years back, if I have to compare test, technologies, automation, this is what I see the difference. Early days, we were being a very innovative organization. We have been introducing new tests. The number of tests which we were talking about in hundreds, now we are talking about in thousands. The new area which got added. So new test addition has been journey. It goes on. It will keep going on. But the new area which I saw getting added in last decade is whole genomics front. Analytical chemistry first time got introduced in clinical labs and so on. So this is a journey and it will continue. More importantly, let me talk about automation, which probably there'll be some overlap with my colleagues, Dr. Deepak, Dr. Avi, they have spoken about. What I see change in automation, if I say automation into three sides, one is equipment automation, second is IT level automation, and third is combination of all the three. Automation in 2000 or before 2000 were talked about is more of a semi-automated batch analyzer or a single testing analyzer or so on. And later on, it migrated to multi-analyte, random access, and full automation. We are moving towards now, we have moved largely to multiple automation coming together, an integrated platform, either through middleware or through complete integration through total lab automation. This is where I see big change on automation occurring, and it's a journey, it will continue. But on IT front, there is a big change. And today, if you ask a good lab cannot stay good until as they are fully IT woven. IT good practices like what you talk about interface with the machines or a good limb system which takes care of right from registration to reporting and post-reporting support. Without that, lab is not good. Your operations is incomplete. And now we are talking about auto validation, auto authorization, and AI being put so that what a lab manager was thinking and reporting or a doctor was thinking and reporting gets thought by the software and reporting gets done. So gradually this work is being taken over by software, by automation. And this is already a reality and it is improving day by day. If I have to talk about few combination, one or two good examples. So in combination, I would say digital pathology, which Dr. Deepak talked about, where your tissue analysis, histopathologists used to do, now it is automated, or we say cytology screening is automated. Immunofluorescence screening is also getting automated and so on. And hematology, we should talk about CBC, which also automatically AI-driven tools can do it. And this is a journey, it will continue. Few things during COVID time, which I came across and I want to talk about, is somewhere there was a big help into improving quality, efficiency, and cost control, all three. So I came across something like tapestry pooling, a good automation, where in a single step, you can do pooling of multiple sample and give the result in better quality than you doing individually. It's very long description, I'm not describing, but like this, innovation, IT is playing biggest role in last 10 years. And I feel in coming 10 years also, this is going to be main game changer. Thank you.
Thank you, Dr. Nilesh. I hope Manoj heard tapestries pooling that you spoke of. He would have loved to speak about that. We're speaking about technology. We are speaking about all the health records. So, Niraj, to you, Make in India for the world, what will it take the Indian healthcare technology creators to dominate global markets in the years to come, like we have done in other sectors?
Yes. So you rightly pointed out that we have already done it in like other sectors like CRM and all, where Freshworks and all have done that. And traditionally, healthcare is usually it runs at least 10, 15 years back than any other industry. They are slow to adopt things. So we have seen that most of the current healthcare, health tech space in the technology space is like maybe it is like ruled by US based old timers like Cerner, Epic, all this. But now with so I believe that for us to like, for example, how we have done it, like we are already serving like clients across the globe. We have 100 plus centers in the US. Somewhere we have also worked with Cerner. So what we have realized is that we have to somewhere work with other players to actually get into that market and then think of capturing it. And when we go to like more developed nations, usual thing that we hear a lot about is like quality and importance of quality and accreditations in terms of whatever they're using technology as well. For example, in India, no one would actually ask you that, okay, are you HIPAA compliant or are you SOC 2 compliant or are you, so no one will ask you that. But there, if you have to sell, that is a must have. So I believe, and in terms of technology and in terms of the tech talent that we have, anyways, most of the things are done from India and that is there already. So the only thing that I think stops us is that how can we like present ourselves as better in quality as well. And of course, the cost advantage would definitely come in, and that will help us scale to a global as a global player as well in the future.
Thank you, Niraj, for those definitely interesting way of looking at it, where given that we want to aspire for quality, it's our choice to put it in. And if everybody is asking for quality, and I think everybody should come together and say, even if there is no regulatory to ask for GDPR or HL7 for interoperability, let's just go ahead and make it because we can, and then things open up. And I think that's clearly what we have seen across all the work that all of you have done. Yeah, you want to add something?
So coming to quality, what I would like to add is quality should not be subjective. Quality has to have set guidelines. It might be relevant to the indigenous population, to the indigenous players. And, it should be defined by the policy makers. And as rightly said, no one usually asks, but now with the growing awareness, people do realize what is the importance of trademark, ISI, ISO, NABL accreditation, CAP accreditation. So that is going to grow even more and more. But at the same time, like coming back to NIPS, which you were asking. So in NIPS, one false negative report can lead to a devastating, chain of events for a family. So then how do we define quality? Is it like a zero or is it like a percentage of total? How do we define it? So there has to be some, a very, very robust guideline put forward for, defining the quality.
I so much agree with him. Quality is such a loosely used term. And when you go in depth, somebody says, I'm a good quality lab or a good quality XYZ services. When you go into detail of it, he has nothing to prove. He has no, it's quality has to be evidence based. There has to be criteria based on, he says, my quality is good. And quality also has got levels, and quality has got many more areas to cover. But it is so loosely used term, unfortunately, in the industry, and the industry where quality matters a lot because you're playing with life of somebody. So I think this is something which we need to take it as a message. Yeah.
Couldn't agree more, I think. And it's good to see that all of you, while you're talking about disruptions and new technologies, you're still hung up on the basics of what makes everything work. So it's fantastic to see. Just to add to Avi, I think I didn't plan of sharing this, but then when we were making our tuberculosis genomics application, we were on a blank slate, and nothing to lose there. And the first thing we said is read up SAMD, software as a medical device, FDA guidelines and what it says, and then read up FHIR, what that means. And it gave us an opportunity of creating a genomic-based analytical method in which a raw genomic data can come in and a report can go out. And that software is now sitting in the GE Edison platform. And the GE Edison platform follows all the guidelines of the US FDA, FHIR, HL7, GDPR, HIPAA, and all of that. And it was not that, it was extremely difficult to put those guidelines in. The difficult thing was to say, let's do it that way. And to have that in the DNA of the company itself and as the healthcare system of India going forward. You have spoken about automation and quality. You have spoken about automation and quality, and all of us have spoken about automation and quality. I think that's the message I want to take forward, even as we get into the future of diagnostics and do a lot of new exciting stuff. The
One
basics
last
will remain the
point I
same.
would add here is that, to make quality more accessible, approachable, and understandable to everyone, I think here I would call upon the support of government to make public programs more favorable to the newer tests, newer diagnostics, newer technologies, so that, we have multifold population compared to the Western and other countries. But the kind of sequencing we do is not even 0.2% of the population. And so to make it more and more quality conscious, I think we will call upon the support of government.
Absolutely. Couldn't agree more. Thank you for those last words. Thank you again, Hasmukh, Niraj, Dr. Nilesh, Dr. Ravi, and thanks again. And it was a pleasure moderating this session. Have a good day, everyone.
Thank you so much, Mr. Chatterjee. The session was deeply informative. I thank all our guest speakers for joining us for this session. I would request 2 minutes more. Can I have Dr. Naveen Nishchal to felicitate Dr. Nilesh Shah, please? I request Mr. Puneet Gupta to please felicitate Dr. Avi Nahar. Next, I request Mr. Sanjay Jha to please felicitate Dr. Deepak Sanghavi. I request Dr. Mini Bodhanwala to please felicitate Mr. Hasmukh Rawal. Next, I request Dr. Sonal to please felicitate Mr. Niraj Desai. Can I please have Dr. Naveen Nishchal to felicitate? Yes. I request Nidhi Goyal to please felicitate Dr. Anirvan Chatterjee. Thank you so much to all our guest speakers. You may please resume your seats.